Hello everybody, thank you for being here with me. My name is Robert Libby. I'm a registered massage therapist and I have had the honor of being invited to be with you today from the amazing people at the PhysioZest magazine, Evolving You One Page at a Time. Thank you so much to founder and editor Dr. Ashi Satia. Please excuse my pronunciations. I'm going to completely pronounce them incorrectly. Business Strategy Director Dr. Samida Deshmukh, and Art Director Dr. Riddhi Gandhi. It is a great deal of honor for me to be with you today. Again, my name is Robert Libby. I'm a Canadian-trained registered massage therapist. I've been practicing for 27 years and I've been an educator for 22 years. I have taught regional spinal orthopedics, neurological assessment, manual therapy. I also teach internationally ligamentous articular strain techniques. You can find out more at lastsight.ca. And I'm also author of one of the best-selling books, Ligament Pain Referral Patterns. You can find that at ligamentpain.com. So I am here with you today because we are going to be discussing some research papers and how to implement that research into practice. As a manual therapist and as a clinician, it's very important to continually keep up with the current evidence-informed research pertaining to manual therapy, our treatments, our treatment effects, our outcomes with our patients. So it's very important to continually advance our education through research and then implement that into practice. So what we're going to be doing is we're going to be looking at three research papers. The first one is Manual Therapy in Diaphragm Muscle, Effect on Respiratory Muscle Strength and Chest Mobility. The next one is The Manual Therapy Diaphragm Release Technique Improves Diaphragmatic Mobility, Inspiratory Capacity, and Exercise Capacity in People with Chronic Obstructive Pulmonary Disease, a randomized trial. And the third one is a clinical study comparison of diaphragmatic stretch technique and manual diaphragm release technique on diaphragmatic excursion in chronic obstructive pulmonary disease, a randomized crossover trial. So I have been asked by the amazing group at PhysioZest to, as best as possible, reproduce the techniques as described in the research papers. So I am familiar with some of these techniques. One I am unfamiliar with, but I will do my best to best reproduce the technique as best described in the research paper. And I would also like to offer some suggestions and my perspective on treating patients and implementing this research into practice. There are times when these treatment techniques are appropriate, and there are times when they are inappropriate for various reasons, and we'll discuss that further on after we have demonstrated the techniques. So let's jump into the techniques. In the left image, we have a nice image from the Netter Anatomy textbook, which shows the respiratory diaphragm and its interdigitations with the QL, psoas major, psoas minor, and it also connects through the parietal peritoneum. In the middle image, this is from another anatomy book. We can see the sympathetic trunk, the greater splanchnic nerve, central tenon of the right lobe. We have the central tenon of the median lobe. We've got the sternal origin, costal origin. There's a central tenon of the left lobe, and the rest of the connections through the respiratory diaphragm. We've got the median and lateral arcuate ligaments, and then the image on the right is an image from Anatomy Trains. It's their perspective on the connection of the respiratory diaphragm through the anterior aspect of the pelvis, the pelvic floor, and then connecting through to the other structures that they describe in their textbook. So this is a three-dimensional image of the respiratory diaphragm on its own. This is an image with the costal margin added in along with the inferior vena cava. the musculature and some of the neurovasculature. This is a cadaveric image showing just the amazing amount of mass that the respiratory diaphragm has along the whole costal margin, from the posterior to the lateral to the anterior aspect, back around to the lateral. We can see through the fascial connections that there is connections in through to the QL muscle, the psoas major, the psoas minor, the ligamentous stocking of the vertebral column. We've got the foramen that are there for the vessels coming through from above and coming up from below. And we've got the central tendon that's a nice white sheet in through there. So it's a very large, massive muscle to attempt to treat. This is an image from the Plastination project in Germany. This is sort of a nice, clean image where they have removed a number of the fascial supporting structures. In the left image, we can see that the respiratory diaphragm sits like a hat over top of the liver, the spleen, the pancreas, the stomach. It sits below the lungs and the pericardium and the heart. It also interdigitates into the falciform coronary round ligament of the liver. We can see in the right that it is higher in the front and lower in the back. It sort of has an angle to it. If we come around to these images, again, we can see more of that respiratory diaphragm and just the mass of that respiratory diaphragm. We can see in the right image more of the liver side where it connects through the falciform coronary ligament. And then we have the posterior aspect of the respiratory diaphragm where it covers all those structures, and we can see the kidneys in the back also and the lungs up on top. Hey everybody, welcome to section 4. In section 4 anatomy, we're going to be discussing the bucket handle motion for the ribs and also the respiratory diaphragm. Now, we like to treat the ribs because they are intimately connected to our shoulders. They're intimately connected to shoulder injuries. And when one part of the shoulder complex is involved, it also involves the rib cage and the thorax. Now, remember that we have our large serratus anterior muscle, which runs from rib 1 all the way down to rib 8. It interdigitates into the intercostals and the costal margins of the ribs and runs into the medial border of the scapula. When treating the ribs, we want to assess to see if they have proper bucket handle motion with respiration. Now remember that these ribs should elevate and depress like bucket handles. And when they don't, then there is involvement of dysfunction through all 3 layers of the intercostal musculature and the fascial tissue and musculature of serratus anterior. So we really need to focus on the intercostal spaces, locating where there's normal space, where there's an increased space, and where there's a decreased amount of space. We want to try and create a balanced environment for those tissues to function within. When it comes to treating the respiratory diaphragm, I honestly feel that this is an area that the respiratory diaphragm hasn't been treated effectively enough. We need to remember that the diaphragm is a large parachute-like structure that runs from the anterior portion of the sternocondral joints. It runs all the way around laterally, posteriorly on both sides, and attaches in through the crus of the diaphragm into T12 and L1. Now, this structure is such a large structure that people don't recognize that you have to involve the whole structure in order to influence it in a positive way so that you can make a change to it. A lot of people, they just like to treat it underneath the costal margin and through here or through here. But you're only getting, at best, maybe 2 to 5%. We also need to remember that it starts at about rib 5. So if we go rib 1, 2, 3, 4, 5, your respiratory diaphragm is up and through here. If people are trying to treat it by slipping their hands underneath the costal margin, well, you're sort of forcing the liver out of place or the stomach and the pancreas out of place through here. So we really need to focus at rib 5 to take full advantage of engaging that full tissue, so that we can disengage it and exaggerate it from its dysfunctional position and really sort of try and establish proper breathing mechanisms through this structure. We like to treat respiratory diaphragm with shoulder injuries and with cervical spine injuries because it's connected through the mediastinal tissue, the pericardium, the esophagus and the trachea, and the endothoracic fascial tissue, which all lead up to the investing fascial tissue, which encompasses sternoclavicular, anterior posterior sternoclavicular capsule and ligamentous tissue, that interclavicular ligamentous tissue, and SCM. So in the way that I treat respiratory diaphragm, I really honestly feel that this technique fully engages that structure and really provides an opportunity to disengage it from any type of dysfunctional pattern that is involving the shoulder. So let's look at treatment for re-engaging proper bucket handle functionality to the rib cage and to effectively and specifically and precisely treating this respiratory diaphragm. Patient's lying in a supine position. The therapist stands above the patient's head. The therapist holding the lower edge costal margin with the tip of fingers curved. My suggestion is either one or two hands, depending on the size of the patient's body. The therapist requests that the patient adapts a slightly amplified breathing and during the inspiration phase exerts a cephalic traction. In the expiration phase, the therapist maintains this traction without increasing it until the perception of no longer being able to pull the tissues. The patient is asked for an exhale apnea and contraction of the belly. The therapist gently relaxes the costal arch at the end of the apnea. The technique is performed twice on each side. So I would do it twice on the patient's right side. I would transfer over to the left side and perform the same technique. Therapist holding the lower edge of the costal margin with the tip of the fingers curved. The therapist requests that the patient adapt a slightly amplified breathing and during the inspiration phase exerts a cephalic traction. Expiration phase, the therapist maintains this traction without increasing it until the perception of no longer being able to pull the tissues. The patient is asked to exhale apnea and contract the belly. The therapist gently relaxes the costal arch at the end of the apnea, and the technique is performed twice on each side. Okay, this is for the lift diaphragm technique. This is for the purpose of generating the stretch of the peripheral fibers of the diaphragm. Patient's lying in a supine position. Therapist standing or seated above the patient's head. The therapist holding the lower edge of the costal margin with the tips of the fingers curved. So I'm just going to come next to you. I'm going to make contact with the lower costal margin here. I'm going to slowly sink into the costal margin to the first depth of reciprocal tension of the tissues. The therapist requests that the patient adapt a slightly amplified breathing and during the inspiration phase exerts a cephalic traction. So take a deep breath in, take a deep breath out. I'm going to increase my contact with the costal margin. You take a deep breath in. I'm going to traction towards me and relaxed. Expiration phase. The therapist maintains this traction without increasing it until the perception of no longer being able to pull the tissues. This technique is performed twice on each side. At the end, the patient is asked for an exhale apnea and a contraction of the belly. The therapist gently relaxes the costal arch at the end of the apnea. So take a deep breath all the way in and all the way out. Out, 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 out. Contract, contract the belly, and relaxed. So again, the patient's in a supine position. The therapist is standing or seated over top of the patient's head. The therapist is holding the lower edge costal margin with the tip of the fingers curved. So I'm wrapping my fingers around the lateral costal margin, meeting the tissue resistance. The therapist requests that the patient adapt a slightly amplified breathing, and during the inspiration phase exerts a cephalic traction. So deep breath in, deep breath out. Expiration phase. The therapist maintains this traction without increasing it until the perception of no longer being able to pull the tissues. This technique is performed twice on each side. The patient is asked for an exhale apnea and a contraction of the belly. The therapist gently relaxes the costal arch at the end of the apnea. So deep breath in. And deep breath all the way out. Contract the belly. Out, 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 out. No air left in the lungs. And that is the end of the technique. So this is for the lift diaphragm technique. Patient's lying in a supine position. Therapist standing or seated at the patient's head. The therapist holds the lower edge of the costal margin with the tip of the fingers curved. So I'm going to come in, I'm going to find your costal margin. The therapist requests that the patient adapt a slightly amplified breathing, and during the inspiration phase exerts a cephalic traction. So you're going to take a deep breath in and a deep breath out. As you take a deep breath out, I'm going to sink in and slightly pull towards me. Expiration phase, the therapist maintains this traction without increasing it until the perception of no longer being able to pull the tissues. The patient is asked to finish, the patient is asked for an exhalation apnea and a contraction of the belly. The therapist gently relaxes the costal arch at the end of the apnea. This technique is performed twice on each side. So let's have you deep breath in again. And all the way out. I'm going to reach in a little bit more and pull a little bit more superiorly and laterally. We're going to hold until the perception of no longer being able to pull the tissues. And then I'm going to have you take a deep breath in and deep breath all the way out and out, 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 all the way out. No air in the lungs. Contract the belly and relaxed. The patient is lying in a prone position. The therapist standing beside the patient, placing the ulnar border of the cephalic hand in relation to the transverse ones. Caudal hand flatten in front of the popliteal fossa. Respecting the patient's breathing rhythm, the therapist makes a divergent support by dropping the weight of his body onto his two hands, which will move away without slipping during the exhalation phase and relaxing that pressure in the inspiration phase. The maneuver was performed for 1 minute on each side. So this is for relaxation of the diaphragm technique. The second technique was the relaxation of the diaphragm, which aims to promote the rhythmic stretching of the double pairs of the diaphragm. The patient is in the prone position, the therapist standing or seated beside the patient, placing the ulnar border of the cephalic hand in relation to the transverse ones. So a hand on costal margin. The caudal hand is flattened in front of the popliteal space, popliteal fossa. Respecting the patient's breathing rhythm, the therapist makes a divergent support by dropping the weight of his body on his two hands, which will move away without slipping. During the exhalation phase, and relaxing that pressure in the inspiration phase. This maneuver was performed for 1 minute on each side. This is for relaxation of the diaphragm technique. The patient is lying in a prone position. The therapist standing or seated beside the patient, placing the ulnar border of the cephalic hand in relation to the transverse ones. The caudal hand is flattened in front of the popliteal fossa. Respecting the patient's breathing rhythm, the therapist makes a divergent support by dropping the weight of his body onto his two hands, which will move away without slipping. During the exhalation phase and relaxation, that pressure in the inspiration phase. This maneuver was performed for 1 minute on each side. I'm going to read through that one again. This is for the relaxation of the diaphragm technique. Patient is in the prone position, the therapist standing or seated beside the patient, placing an ulnar border of the cephalic hand in relation to the transverse ones and a caudal hand flattened in front of the popliteal fossa. Respecting the patient's breathing rhythm, the therapist makes a divergent support by dropping the weight of his hands on his weight of his body on his two hands, which will move away without slipping during the exhalation phase and relaxing that pressure in the inspiration phase. The maneuver was performed for 1 minute on each side. Patient is positioned supine with relaxed limbs. The therapist positioned at the head of the patient. Manual contact with the pisiform, hypothenar region, and the last 3 fingers bilaterally to the underside of the 7th to 10th rib costal cartilages. Therapist's forearms are aligned towards participant's shoulders. Inspiration phase. The therapist gently pulls the points of contact with both hands in the direction of the head and slightly laterally, accompanying the elevation of the ribs. Exhalation phase. The therapist deepened contact towards the intercostal margin, maintaining resistance. In the subsequent respiratory cycles, the therapist progressively increases the depth of the contact inside the costal margin. The maneuver was performed in 2 sets of 10 breaths with a 1 minute interval between them. This is for the manual diaphragm release technique. Patient is positioned in a supine with relaxed limbs. The therapist positioned at the head of the patient. Manual contact with the pisiform, hypothenar region, and the last 3 fingers bilaterally to the underside of the 7th to 10th rib costal cartilages. So we're going to have bilateral contact with the fingers of the costal cartilages, 7th to 10th ribs. Therapist's forearms are aligned towards the patient's shoulders. Inspiration phase. The therapist gently pulls the points of contact with both hands in the direction of the head and slightly laterally, accompanying the elevation of the ribs. In the exhalation phase, the therapist deepens contact towards the intercostal margin, maintaining resistance. In the subsequent respiratory cycles, the therapist progressively increases the depth of contact inside the costal margin. The maneuver was performed in 2 sets of 10 deep breaths with a 1-minute interval between them. So let's have a deep breath in and deep breath out. This is for the manual diaphragm release technique. Patient positioned supine with relaxed limbs. Therapist positioned at the head of the patient. Manual contact with the pisiform hypothenar region and the last 3 fingers bilaterally to the underside of the 7th to 10th rib costal cartilages. Find the costal cartilage. Costal cartilage. Both hands are here. Therapist's forearms are aligned towards the participant's shoulders. Inspiration phase, the therapist gently pulls the points of contact with both hands in the direction of the head and slightly laterally to accompanying the elevation of the ribs. Exhalation phase, the therapist deepens contact towards the intercostal margin, maintaining resistance. In the subsequent respiratory cycle, the therapist progressively increases the depth of contact inside the costal margin. This maneuver was performed in 2 sets of 10 deep breaths with 1-minute interval between them. Okay, deep breath in. The patient sits erect for the intervention. The therapist standing behind the patient passes their hands around the patient's thoracic cage, introducing fingers into the subcostal margins. The patient's trunk was rounded slightly to relax the rectus abdominis. As the patient exhaled, the therapist easing their hands caudally, grasping the lower ribs of the subcostal margin. This firm but gentle traction was maintained as the patient inhales. This is performed in 2 sets of 10 deep breaths with a 1-minute interval between the sets. This is the diaphragmatic stretch technique. Patient is sitting erect for the intervention. The therapist is standing behind the patient. For my purposes with my patients, I am always concerned with boundaries and consent, so I always place a pillow between myself and my patient, regardless of if the patient is male or female. The therapist passes their hands around the patient's thoracic cage, introducing the fingers into the subcostal margins. So I'm going to come out from behind you, from underneath the rib cage. I'm going to have both hands on the costal margins here. The patient's trunk was rounded slightly and relaxed the rectus abdominis. As the patient exhaled, the therapist increases their hands caudally, grasped the lower ribs at the subcostal margin. So take a deep breath in and a deep breath out. This firm but gentle traction was maintained as the patient inhales. So take a deep breath in and a deep breath out. And this is performed in 2 sets of 10 deep breaths with a 1-minute interval between the sets. And then coming out slowly, sitting up nice and straight. This is the diaphragmatic stretch technique. Patient is sitting erect for the intervention. The therapist standing behind the patient. The therapist places their hands around the patient's thoracic cage, introducing fingers into the subcostal margins. So I'm going to come underneath you. I'm going to find the subcostal margins. The patient's trunk was rounded slightly to relax rectus abdominis, and as the patient exhaled, the therapist eases their hands caudally, grasping the lower ribs at the subcostal margin. This firm but gentle traction was maintained as the patient inhales. It's performed 2 sets of 10 deep breaths with 1-minute intervals between the sets. Okay. Okay, so this is an alternative treatment technique for the respiratory diaphragm. This is a side-lying position that I use in my own practice. We have the patient lying side-lying as close to the edge of the table as possible, as close to the therapist as possible. The therapist is going to lean their hip, their greater trochanter of their femur, into the patient's mid-thoracic cage, then slowly finds the lateral costal margin with both hands, slowly sinks the fingers around the subcostal margin and starts to traction the subcostal margin superiorly, cephalically, and laterally. The patient can take a deep breath in, and as the patient takes a deep breath out, the therapist slowly sinks the fingers more into the subcostal margin and exerts more of a lateral traction, respecting the reciprocal tension of the treatment tissues. This is held until at which time there is no resistance from the patient's tissues. And once this point is attained, then the patient can take their same side arm slowly over top of their head to a nice comfortable position. As long as there's no shoulder pathologies or concerns, the patient can do this. If there are shoulder pathologies and concerns, then we don't include this aspect of the technique. Once the arm is over top of the head, the therapist then has a little bit more elasticity to the tissues and can exert a final lateral and superior traction on the subcostal margin, matching the reciprocal tension of the tissues in this area. The patient breathes normally, and this is held until which point there is no tissue resistance being felt by the therapist. And once that point is attained, then I'm going to get you bring your arm back down. And the therapist releases their contact with the patient's costal margin, and the treatment technique comes to an end. So this is an alternative technique for respiratory diaphragm. What I like to do is have my patient lying on their side near the edge of the table, have a pillow for support at their head. I like to contact the full lateral side of the rib cage, making sure that I have my 5th finger in contact with the lower costal margin. Each of my other fingers interdigitate into the intercostal space. I have full contact into the lateral costal margin, and what we do is we instruct our patient to take a deep breath in and exhale all the way out. And as they exhale all the way out, the therapist lowers their pressure towards the table, drawing the respiratory diaphragm medially towards the center. We are matching the reciprocal tension of the tissues This technique is performed in 2 sets of 10 repetitions and held until at which point you can no longer feel any resistance in through the tissues. At that point, if your patient doesn't have any shoulder pathologies or concerns, you can take your right arm above over top of your head, and the therapist can increase pressure again medially towards the table. This causes an elevation of the rib cage, placing more traction on the respiratory diaphragm, but also allows the therapist to compress more medially, causing a lengthening and relaxation of the respiratory diaphragm. We meet the tissue resistance until at which point it can no longer be felt. At the end, the treatment is at the end. And I can get you to bring your arm back down. And take a deep breath in. And as the patient inhales fully, the therapist releases their compression onto the lateral rib cage, and the treatment is done.